series. We're very excited to bring you this webinar where you'll learn more about pain management, an emerging field within the practice of naturopathic medicine and SCNM's new Pain Relief Center. My name is Eve Adams, and I will be your host for today's webinar. Before we begin, let me take a moment to familiarize you with the technology that we'll use for today's webinar. First, make sure that you can see my screen, which currently shows an image of a webinar control panel. Make sure that the control panel box on your computer is expanded. There should be a box like the one shown in the upper right-hand corner of the screen. If you do not see the box, look for a double arrow. Click these arrows and your box will expand. You'll have the opportunity to ask questions. To do so, you'll type your questions into the box indicated here. Your questions will be answered verbally after the presentation is complete. We anticipate today's webinar to run approximately 60 minutes, roughly 40 minutes of presentation, followed by about 20 minutes of questions. During this webinar, you'll be hearing from SCNM President and CEO, Dr. Paul Mittman, SCNM Executive Vice President, Christine Girard, and Klee Bethel. Dr. Paul Mittman is SCNM's President and CEO. During his career, he practiced naturopathic medicine for 25 years, chaired the homeopathy department at SCNM, conducted research, was the first naturopathic physician published in a peer-reviewed journal, and helped raise 2 children, one who's currently a third-year student here at SCNM. SCNM is the only naturopathic college to have a president who holds a Doctor of Naturopathic Medicine degree. He also earned a Doctor of Higher Education Management from the University of Pennsylvania. We're fortunate to have a president dedicated to making SCNM America's healthiest college. Dr. Mittman is a competitive cyclist and follows a plant-based diet. He practices what he preaches and believes wholeheartedly in the healing power of nature. Dr. Christine Girard has served as Southwest College of Naturopathic Medicine, has served at SCNM since 2005. She began as the college's Chief Medical Officer in 2009 and was promoted to Executive Vice President of Academic and Clinical Affairs, and in 2012 became the college's Executive Vice President. Dr. Girard's career has focused on leadership in undergraduate and postgraduate naturopathic medical education and hospital-based integrative medicine. Dr. Girard is the former Director of Naturopathic Medicine at Southwestern Regional Medical Center in Tulsa, Oklahoma, a Cancer Treatment Centers of America hospital. She's the co-founder and past co-director of the Integrative Medicine Center at Griffin Hospital in Connecticut. She's a current student in the University of Arizona Masters in Public Health program based here in Phoenix. And last but certainly not least, you'll hear from Dr. Klee Bethel. Dr. Bethel is a boarded anesthesiologist. He completed his residency in anesthesia and interventional pain management at the University of Arizona in 1991. He's been practicing interventional pain medicine with a naturopathic focus for the last 25 years. He's current Chief of Staff at the Arizona Spine and Joint Hospital since 2004. He has served as medical director at numerous hospitals here in the Phoenix area. His relationship with SCNM began when he joined the Board of Trustees as chairman, serving in that capacity for 9 years. Dr. Bethel has recently moved his practice to the SCNM Pain Relief Center, and with the help of several faculty and staff, is putting together a truly integrated practice which will serve as a model for centers throughout the world. And that's, of course, what we're here to talk about today, and I know you're all very excited to hear from these 3 leaders in naturopathic medicine and pain management. So with that, I will turn it over to Dr. Mittman to get us started.
Thank you, Eve. So this is a photo of Dr. Bethel, Dr. Girard, and myself. We were at the Samueli Institute in Alexandria, Virginia a couple of months back because the college is participating in a chronic pain breakthrough collaborative, which we'll talk a little bit more about later on in the presentation. But it's really interesting how the Samueli Institute has really based this on the need for a more effective approach to pain, particularly in the military. In fact, the collaborative is being chaired by the former Surgeon General of the United States Army. So see. The objectives for today are, we're going to give a little bit of background on just the scope and the severity of the issue of pain in the United States. We're going to talk about the role of naturopathic medicine, both historically and currently, and as from our perspective, what we see the future of naturopathic medicine in treating pain, both from a profession standpoint, but also as from perspective of from a career standpoint. And then we're also going to talk about the Pain Relief Center, and where did that come from? And this is something that has never been done in the field of naturopathic medicine and naturopathic medical education. And so what drove it in the first place, and what do we hope to achieve there? So, as you can see, there are a lot of people in the United States who suffer from chronic pain. In fact, chronic pain is the leading cause of presenting problem for physicians across the spectrum. And interestingly, the Institute of Medicine estimates that not only do 100 million people suffer from chronic pain in this country, but also the cost to our society is over $500 million. And you can see in the graph on the screen that that kind of dwarfs a lot of the other leading causes of both morbidity and mortality in the United States. So the answer in our country to this problem is an explosion of prescription use. And since 1999, the amount of prescription painkillers prescribed and sold in the United States has nearly quadrupled, even though the numbers of people suffering from pain has not changed dramatically during that time. I don't know if you've seen that, Dr. Bethel, in your practice, particularly the use of opioids.
I have not seen an increase in opioid use in my practice. In fact, over the last 10 years, I've seen a decrease in opioid use in my practice. However, my practice does not necessarily reflect the general pain practice.
Is that something that kind of surprises patients when they come in? Because I imagine a lot of patients that you see would have been people who've been referred to you either by other pain interventionists or other people who would have been prescribing painkillers.
Most patients on opioids within my practice came to me on opioids. Generally, what I try to do is identify their pain, where it's generated, and perform some intervention to reduce or eliminate that pain. And once the pain is decreased, then it's much easier to reduce the opioid dependence.
Great. So, other than Dr. Bethel, you could see that the rest of the practice of medicine has relied increasingly heavier prescribing for opioids. I mean, just looking at OxyContin sales in the United States are, I think, almost 2 million Americans have prescribed these or actually abuse these, but the number of prescriptions in this country has increased during that period from 131 million to 210 million people on opioid painkillers, which is pretty astounding. From a public health standpoint, Dr. Girard, how does this strike you?
It strikes me as a crisis, and often when we're talking about opioid medications, we're thinking of dependency issues and perhaps overuse of them. What people tend not to remember is that death can be a result of using or misusing opioid pain medications. And since the year 2000, this country has seen a 3.4-fold increase in opioid-related deaths alone in this last decade. And that actually competes with and exceeds street drug use and deaths from street drug use.
But they are related phenomena.
They are. One can lead to the other.
If you take away their prescription medication without addressing their dependence or their pain, then you end up with previously normal Americans using illegal opioid substances like heroin. Unfortunately, because they're naive, they didn't grow up on the streets using illicit drugs. They're somewhat naive, and they end up having a lot of the problems that we saw in the 80s with illicit drug use, and that was the development of AIDS and hepatitis A, B, and C, or B and C. We're starting to see that again in the, there was an article in Time earlier this year about the spike in Midwestern housewives that were coming down with AIDS because of the withdrawal of their opioids from their doctor that they were dependent on, and their subsequent venture out into the streets to find something to help them with their dependence, and weren't street savvy enough to use clean needles and ended up getting AIDS.
Yeah, it's almost a paradoxical phenomenon. I remember just a couple of years ago, the governor of Vermont dedicated the State of the State address to the heroin epidemic in Vermont, which would have been, almost inconceivable 30 or 40 years ago, at a time when heroin use in the United States was actually pretty high. So we're here actually not to to persist on the current problem, but really to look at alternatives to to relying so heavily on the pharmacologic management of pain. And so in terms of alternatives, let's look at naturopathic medicine in the 20th century. I don't know if people who are on the webinar know this, but naturopathic medicine, osteopathy, and chiropractic all emerged at the same time in the latter part of the 19th century. And so throughout the 20th century, naturopathic medicine always had a pretty hefty helping of physical medicine. And in fact, until the 1950s, most naturopathic medical schools were affiliated with chiropractic schools and chiropractic programs. And in fact, I think the last chiropractic program that offered naturopathic medicine was in 1956. And when that was discontinued, that was the advent of standalone naturopathic medical schools. And so this this history and tradition of physical medicine and manual therapies, manipulation, goes back a long way for naturopathic medicine. So the modalities for that were used in the 20th century were manipulation or adjustment, physiotherapy, therapies like therapeutic ultrasounds, E-stim, sine wave, and then interferential therapy, and then microcurrent therapy as we got closer to the 21st century, and then some really interesting approaches like using cold lasers and other more technologically refined approaches. I think that there was a time in the profession, and I think that it still persists to some degree, that there was like an either-or, and when I first started out in 1985, I can't think of an ND who was working, who was co-managing patients closely with a medical doctor, let alone practicing with a medical doctor, let alone sitting between a naturopathic physician and a medical doctor to talk about, creating a new model of care at a naturopathic medical school. And, to a large degree, we have Dr. Girard to thank, because I think your background in your training, particularly at Griffin Hospital and at Cancer Treatment Centers of America, really opened your eyes to what was possible when the professions worked together.
Sure. the beginning of my career was quite heavily spent in hospital-based integrative medicine at Griffin Hospital, where I completed residency and went on to create an integrative medicine center that was an outpatient treatment center for general practice. And tied to that was a prevention research center where we conducted clinical research on a variety of things, cardiovascular disease and integrative medicine being two of those things that we studied. It was interesting at the Integrative Medicine Center because we had students and residents involved in our model of care, and it was through that, if you will, beginning time of developing our model of care there that we were able to publish a paper on educating allopathic, osteopathic, and naturopathic medical students and residents in an integrative setting. And it really struck home for me the importance of interprofession education as we create teams who work together. Often patients like that a lot. They have more than one person that they can work with and find that they like that attention. In addition, we find that we have a more streamlined approach to finding the right therapy or the right combination of therapies for an individual patient. Then my next experience was at Cancer Treatment Centers of America, where their model of care is integrated across everything. The scheduling, the entire hospital system is an integrative approach. And again, it was very, very strong within the interprofession education because we had residents in that system, but also in teamwork or team-based medicine. So those experiences definitely have brought me to a place where when we talk about the Pain Relief Center, or the PRC as we call it, I think about how to tie those pieces together, not only to create a great opportunity for students and residents to learn from each other and other disciplines, but also to provide patients novel approaches to care that they might not otherwise be aware were available to them. It also puts the patient in a position where the patient doesn't have to be their own advocate. They're having their providers and family members advocate for them. And so as we as providers are talking to each other about a case or on behalf of a particular patient, we end up brainstorming and we end up thinking about what is the best approach for this patient, and often can provide them with some really unique opportunities to heal.
That brings us to naturopathic medicine in the 21st century. And I think your experience prior to coming to SCNM, I seem to recall, was part of the reason that you wanted to come here, because I think philosophically the school embraces, an integrative approach as opposed to an either or let's dwell on the way things used to be in some sort of bygone era, as opposed to looking ahead as to not only what is best for our patients, but really what's the most sustainable and fruitful future for the naturopathic profession itself.
Well, I think you're right. I mean, one of the many reasons that I came to SCNM is because of the innovative nature of the college. And we're known within the naturopathic medical profession as being the innovators. And what we're talking about here with the Pain Relief Center, really bringing someone like Dr. Bethel in and operating and working with him side by side and on behalf of patients, is something that's not done regularly within our profession. And so the integrative model of what we're talking about, I think, is innovative and is a really interesting approach that is effective and certainly beneficial to patients.
So looking ahead, we're going to talk about some therapies that are historically not, it's a combination of modalities and therapies that NDs have used for over 100 years, together with some newer therapies. And the challenge or the pitfall is in losing sight of really works when a patient gets better, which is really the beast metacontrix naturae, the healing power of nature, which is the capacity that each of us have as living organisms to maintain homeostasis, to create equilibrium in our bodies and in our lives, and that we have a healing power that, when unencumbered, can drive us towards greater health and away from disease. In Chinese medicine, we call this, it's called the qi. In Ayurveda, it's prana. Naturopathic medicine, it's the beast metacontrix naturae. In homeopathy, the vital force. There's always, in chiropractic, the innate. And in fact, I think all healing professions, and with a nod to Dr. Bethel, as coming from an allopathic background, the beast metacontrix naturae was first articulated by Hippocrates, and so it's really not unique to naturopathic medicine. But what is this conceptual framework called the therapeutic order, which is how you put all of these pieces together, so that it's not just a laundry list of treatments that you can do to patients, but how does this all work together? And so I'll just quickly give people a little update on this. First you have to come up with a diagnosis, which sometimes I call it a naturopathic diagnosis, or just a diagnosis, or it could be patient-directed care, which is involving the patient in her or his own care. TLC stands for therapeutic life changes: diet, exercise, dealing with stress. The beast metacontrix naturae could be just as simple as hydrotherapy or water treatment. Acupuncture is a way to stimulate the healing power of nature. Homeopathy, mindfulness, mind-body medicine. This area here, the systems or organs approach, is really interesting because, a lot of times you may need to support the gastrointestinal tract, even though the seat of the patient's problems might not be the typical GI complaint. I know in pain, Dr. Bethel, that there are a lot of pathways for pain and a lot of modulators from pain. The gastrointestinal tract creates more neurotransmitters than any other part of the body outside of the central nervous system. I don't know what your experience has been over the years in working with people, whether it's their gut flora or their microbiome, or just changing people's diet so that they're less inflamed because they're eating less sugar or less saturated fat or less trans fats, etc.
Those are all important in the management of chronic pain.
And then this idea of structural integrity, it could be anything that we do that's a manual therapy, whether it's massage, manipulation, surgical intervention, is a way to address the person's structural integrity, particularly as it relates to pain. But then getting down to the root cause of a person's problem. How many times have you seen a patient walk in and you could tell from their gait, that the problem in their back, or you look at the wear on their shoes, sort of uneven wear on their shoes, but the problem in their back, maybe what they're feeling today, but at some point in their history, it could have actually started in their knees or down in their feet or in their gait, the way that they walk.
You're correct. The presenting symptom is often like a leak in your ceiling that you notice dripping from the light fixture. Replacing the light fixture wouldn't do any good. You have to backtrack and figure out where that water is coming from, in this case, where the pain actually comes from. And to get to the real diagnosis of what's actually happening, you have to do some detective work and follow that trail back to where its origin is. Along the way, you may discover a lot of other things, like a very unhealthy diet that's contributing, a sedentary lifestyle that's contributing, a poor family support structure which contributes, chronic history of depression, perhaps mania. So as you're evaluating the patient, all these things can come to light. And to really produce the optimum result in restoring this patient to homeostasis, if you will, you may need to address each and all of those issues.
So this addressing the pathology, could be getting at, something that developed many years before to be something unrelated to the, the apparent site of the pain. Low back pain, perhaps with an etiology that has something to do with depression or anxiety, and I think here it's really important for us to recognize that you have to do a really careful history and physical examination, because someone could have, back pain that, can represent a bony metastasis, so it could be cancer related, or it could be the manifestation of another chronic disease that's not, what we normally ascribe to a musculoskeletal problem.
Correct, and there's a lot of red herrings, if you will. A lot of symptoms are misleading. Shoulder pain may actually be a liver problem. It could be a spleen problem, gallbladder. Pain in the knee with swelling may actually be gonorrhea. I'm sure you know that. So you really have to have a careful history so you kind of get a head start on what direction you're going to take the interview and the examination. If you don't have a satisfactory answer by the time your history and physical is done, then you're going to want to order some tests to help you refine your suspicions, come to a diagnosis.
Mm-hmm. And so the whole purpose of this therapeutic order is to, it's not a hierarchy. It's not that one is better than the other. Because a patient who has chest pain because they're having a heart attack or an MI, myocardial infarction, at some point it would be good to change their lifestyle, but today might not be the day for that. Or if someone has a tumor that is pressing on a nerve, again, addressing or removing that pathology is key there. On the other hand, I would say the vast majority of people who come in chronic pain are not, have problems that are really amenable to the kinds of treatments that we have at our disposal here, and particularly in an integrative approach at the Pain Relief Center.
I think the naturopathic world offers a lot more options to the treatment of chronic conditions, pain being one of those chronic conditions. And interestingly, people with chronic pain frequently, in fact perhaps the majority, have other chronic conditions that go with it that are not well managed with prescription medication. And so the naturopath has lots of opportunities to impact that patient's health with all the modalities available to them.
Well, even for a lot of people, just losing weight is one way. Eating a less inflammatory diet is another way. So these modalities that are up on the screen are, it's a list of available modalities. Some of them for many years, like I mentioned, manipulation or nutrition. Some of them more recently within the naturopathic armamentarium, particularly pharmacology and also acupuncture. Next picture is where we are sitting right now, which is, could you point to the room where we are? And then we'll all just wave that. We're in the community commons, and we built this building for a number of reasons. But part of it had to do to create the Pain Relief Center, which to us is a laboratory. It's an experiment, but it's also a glimpse into both the future that connects with our past. I think that, I was having lunch earlier with an internist who works with a naturopathic doctor who happens to be on our board of trustees, and we were talking about getting outside the box, or kind of breaking down the walls to where people get, where people get care. Most people think that they're going to get care in the exam room, or in the procedure room. And in reality, people get sick in the rest of their lives, and so it's important to incorporate as many other elements of their lives. And so the cafe, you can see it says cafe there, is an organic, gluten-free restaurant. And so part of the idea, both for the pain center patients, but also in our medical center, which is in another building on campus, is to offer patients an opportunity to eat healthy food. And then adjacent to the room next door to our, off to the side, is a yoga studio. And there was just a Tai Chi class, there was meditation, there's yoga being taught there. And so, again, the more that we can engage patients in having a truly holistic approach to their health, the better they'll be. And I don't think that there's anything especially, that much more effective of doing, any naturopathic modality if you don't pay attention to these things. I know, Dr. Girard, from a public health standpoint, we're talking about determinants of health. And for a lot of these patients, it might not be immediate, but the more access that they have to healthy food, to movement, and I know that was some of the thinking behind having a teaching kitchen on campus as well.
Certainly. So often when we're working with patients, if we're talking about diet change, it's easy in the consultation room to talk about things, but once the patient walks into the grocery store, they don't know how to shop any longer because everything that they normally buy is now off limits. Or they're brave enough to buy something that they've never bought before, and they bring it home and it rots on the counter or in the refrigerator. And having,
and then they go out to Denny's.
Right, exactly. And so having Nourish on campus where patients can experience the type of food that we're wanting them to eat that will help reduce the inflammation and pain to some degree, and then also to help teach them how to cook will go a long way. So there are many modules, if you will, to this building that help create a full picture for patients. The other thing also to mention, along with the determinants of health, is culture. Depending on the culture of the individual patient, we may have a different way that we need to approach things, or different things that we need to be aware of, because while pain is very subjective, it also is within a cultural context and familial context. So we really are talking about not just whole person care, but in some cases whole family or community care.
So that I'm looking at Ms. Adams. That could be another webinar because we do have 9 community clinics.
We do.
And the United States is already, from a demographic standpoint, a lot different than it was 30 or 40 years ago. I think it's really important for our students to experience, to gain experience in patient care in as many diverse populations as possible. You know what I just remembered? That the 3 of us taught a plant-based nutrition class. And when you were talking about people coming home and not finding anything to eat, and so remember when you used to you would do a cooking demonstration, right, and everything was kind of like jury rigged, like we'd bring in hot plates and things like that. And I don't know to what degree that drove us to wanting to have a teaching kitchen, but I think the idea of you schlepping all of your herbs and spices from home as opposed to having a nice place here where we can just offer them. That's kind of an aside. Is anyone still listening? Because we're still having a conversation here. Okay, good. All right. So these are some of the treatments that didn't exist. Really, I would say pretty much through the 20th century. Mindfulness and behavioral health The first publications were in the late 1970s, and before that people did biofeedback, but I think that's an increasingly important part, as Dr. Bethel mentioned, that a lot of people come in with other comorbidities, including mental health problems, but it really gives us an opportunity to access probably the most powerful tool that patients have, which is the ability of people's minds and consciousness to affect how they perceive and experience pain, and to incorporate that. Do you want to talk? Oh, we'll go to the next slide. So that must be the community commons also. It's actually, you can see if you look under the stairs, for those who are on the webinar, you'd have to kind of squint, but you can see that's the teaching kitchen there. The Pain Relief Center is on the first floor, and looking at injection therapies, historically, going back in your career, Dr. Bethel, things like doing epidural and injection therapies, have been used for a long time. You hear about athletes who get a cortisone shot. But what we are looking at today, and treatments that you've helped pioneer, are treatments like prolotherapy and some others. Would you mind, giving people like a quick primer on prolotherapy?
Well, I'm actually going to start with steroid injections.
Okay.
Because when you're talking about injection therapy for pain, for damaged tissue, for inflammation, you really can go one of two directions. One direction is suppressive therapy, and that's your steroids with or without local anesthetic. And that's useful if all you want to do is temporarily suppress inflammation and perhaps relax some muscle, some either smooth or skeletal, and produce improved blood flow. That's a useful thing to do. However, if you've done that once or twice and it's not resolving the issue, then you really need to start thinking about going the other direction, which is regenerative therapy.
Plus with the steroids, doesn't it, the more you do it, doesn't it have an adverse effect on the tissues?
Yes,
themselves?
yes. You can make the bone osteopenic. In extreme cases, you can get pathologic fractures. There's a lot of side effects to steroids used frequently, chronically. Very rarely there's someone that has significant side effects the first time they get a steroid injection. So there's that. And then philosophically, regenerative therapy is more appealing. And thinking of it as a bunch of steps going up to the top of the platform, if you will, prolotherapy is the first step. And that's a solution which is, as its central component, has some form of sugar, usually dextrose. And that is a chemoattractant to fibroblasts, which help remodel the tissue. Different prolotherapists have different solutions they use, which may contain other substances. I like to put a little Tramil or Zeal in mine. If muscle spasm is a predominant factor, I put in some Spascupril.
Those are homeopathic.
They're homotoxicology, actually, but they have their roots in homeopathy. Then the B12 and folic acid are important cofactors in the healing, so I usually add those into a prolotherapy solution.
So it's almost like you're stimulating the healing power of nature. You're putting something there.
I'm telling it where to happen. I'm creating a priority. The healing power of nature exists there and throughout the body. I'm just waving a flag saying, come on over here and work on this for a while.
Sticking a needle.
Yeah. So, and that may be dry needling. may have that effect to some extent also. PRP, platelet-rich plasma, is the next step on the ladder, and that's where you take about 60 cc's of blood, and you centrifuge it, and you take off the platelet-rich portion, and inject that into the affected tissues, ligamentous strain, where things are been stretched out or torn. And once again, that's a more powerful attractant. And in addition to being an attractant, it also contains a small amount of stem cells and cofactors that are needed to heal a tissue. On the next rung, well, that's actually me with my fluoroscope.
And what do you use a fluoroscope for? Because I think the other thing about what we're doing here at the school that's pretty unique is I'm not aware of any other naturopathic medical school, but I only know of one other naturopathic physician in the United States who uses a fluoroscope.
You're probably correct. It's a rare thing. A fluoroscope is just a standard X-rays, which takes live motion pictures. Normal X-ray, you have to be perfectly still or it blurs the image. The fluoroscope is developed to follow motion under an X-ray beam. So with it, I can use a liquid which shows up under an X-ray beam. We call it contrast. And from injecting it, you can tell if not only if you're in the space that you want to be, but often more importantly is you're in a space where you shouldn't be. And so it's much safer to do a lot of the deep injections into the spine, certainly in the neck and the head, much more safely than you can with other imaging technologies, or in particular without an imaging technology. So continuing to move up the ladder is autologous stem cell injection. There's different ways to get the stem cells. Autologous stem cells, you pretty much, you banked umbilical cord cells or your amniotic fluid. Not many of us over 10 have done that, I don't think. And not many of us at 10 need that. So that might be applicable in the future. The more common forms of autologous stem cells are bone marrow derived or adipose tissue derived. Bone marrow, you do a bone marrow aspirate, and then you centrifuge it, and you take the stroma and stem cell rich portion of that solution, and that's your injectate. With adipose cells, you separate the cells from the stroma and the fat. Well, there's a lot of connective tissue in fat. So in one way of separating the stem cells, you get rid of the fat and you keep the stroma. Now, that's particularly useful for joint injections. In another way, another method of preparation, you eliminate the fat and the stroma so that you just have stem cells. And that's particularly good for IV stem cell use. And so the stem cells currently are the top of the platform.
I have to say, from my own personal experience, I had a couple of disc lesions, not quite a year, last fall, that were pretty incapacitating. And the stem cell treatment, most people think of stem cells as you're going to inject cells and they're going to differentiate into new tissue. My results, I had results within 48 hours, whereas before I was lying down, and within 48 hours I was back at work and sitting and operating, as freely as I was, months before. And so I suspect that there's something else going on than what people think about when they think of stem cells.
When you inject stem cells, It turns out as they die and lice open up, they release a extremely powerful anti-inflammatory substance, which we have not identified yet. It's far more potent than any steroid, than any non-steroidal anti-inflammatory. And that's why you get that effect. And that effect can last up to 12 weeks. So that brings you through the first 3 stages of healing. So by the time that effect has worn off, you've already substantially healed most tissues. The discs are a special exception where healing is extremely slow, and we look at 6 months to a couple years for a disc to do any significant healing. And that's why your MRI results do not track with your symptom results.
Right. Again, that's an interesting modern expression of the healing power of nature.
Yes. Yes, and it was all from you.
Right. It's autologous. You know, we have just a few minutes left, and I wanted to ask Dr. Girard, you know, to briefly give us an overview about what we're doing at the Chronic Pain Breakthrough Collaborative through the Samueli Institute, because, you know, the idea that, you know, wouldn't it be great if we could put all of these, you know, wonderful, you know, practitioners and modalities together in the same room, you know, just leave them alone, and magically it means that everybody's going to work together, coordinate and collaborate, and really historically, you know, sometimes that happens, but it doesn't always happen. And so the reason that we were in Alexandria a few months ago, and we'll be back in about 2 weeks, is, you know, to work with you know, some real experts in this area, so that we can have the, you know, the reality of our pain relief center, you know, live up to the dream.
Sure. So the Samueli Institute is a philanthropic organization based in Alexandria, Virginia, founded by a husband and wife team. And one of their arms of funding is integrative medicine. And the Chronic Pain Breakthrough Collaborative is a particular type of collaborative that includes academic health centers similar to SCNM, military, VA, some private centers as well. And the idea is that we are working together to look at the quality of care and to increase access of care for pain patients through a model that's more of a whole person or whole person-centered care model rather than the opioid treatment. The idea is to find ways to have sustainable treatments that are non-opioid. Also, one of the goals of the collaborative is to support something called patient self-efficacy, which is basically the patient's ability to participate in their own care and help with the decision-making process. And finally, the collaborative is hoping that each of us find ways to build a sustainable business model so that this integrative model of care that focuses on whole person care, patient self-efficacy, is something that's sustainable as a business model and can be reproduced throughout the United States. Each of the organizations has its own unique center and way of doing business. And the collaborative is focusing on a quality improvement methodology so that we don't need to do everything the same as every other center involved with a collaborative, but rather we're looking at improving our own processes and learning from other organizations so that we can improve everything that we're doing on behalf of those patients. We've had one in-person learning center or learning session at this point, and we'll have additional sessions throughout the course of this year. And as we have been working together, it's kind of bringing us back to some of the ideals of team-based medicine, and also how to incorporate education within the context of the work that we're doing across all the organizations in the collaborative. but also specifically at the Pain Relief Center. And so from a prospective student standpoint, it's important to know that students can participate in patient care in the Pain Relief Center under the direct supervision of their attending physician. In addition, we have residents who are in training, postgraduate medical education at the college, and they're also involved in the work that we're doing at the Pain Relief Center. And Dr. Bethel and I have had multiple conversations about creating a specific or specialty residency program that would probably be a second-year program for pain management specifically. So that's not yet happened, but we're definitely, we have that on the table, something that we want to have happen.
As I become more familiar with the residents and the actual volume of material that will become necessary for them to master, it may actually become a 2-year fellowship.
And that's fine. You know, as we talk about it, we need to get those graduates through their first year of residency and then into some specialty training. And you know, toward that end, there's a lot of health workforce planning that's going on across the United States, especially in rural areas. And the types of things that we're doing, especially when we start looking at post-grad med ed, we're really priming our graduates to be eligible for these positions as different states and counties are doing health workforce planning. In the Pain Relief Center, we're also providing continuing medical education, and we're in the process of launching a certificate program in pain management as well. So there are a number of different types of education that happen in the Pain Relief Center, and it's one of the ways that we as an organization know that we're doing the right thing. We're making sure that we're doing activities and growing in areas that are mission-centric. And as a naturopathic medical school, it's very important for us to be able to offer students and graduates good opportunities for training, but also to set them up for success as they graduate.
Okay, well, thank you. And I think the program that we're describing is just one facet of, you know, naturopathic medical education at SCNM. It is the first in the profession, and I assume that it will, you know, be part of what's incorporated into other schools. But you know, we take particular delight in doing things first, which is sometimes a little bit painful in itself, like being the first school to switch over to electronic health records, being the first school to change the curriculum into a more systems-based approach. And you know, and for me, particularly as a naturopathic physician, you know, it's really important for me to see as many career pathways for our graduates, and this is just one of them, in addition to women's health and cardiovascular health and treating diabetes. But I think that this is something where, if you think about the tools and modalities and the philosophy behind naturopathic medicine, you have something very special to offer. So I want to thank Drs. Girard and Dr. Bethel for joining us today, but also for all the work that you've done, because really there would be no SCNM part of the collaborative without you guys, and there'd be no Pain Relief Center without you. And so let's take some questions.
Great. Thank you also, Dr. Girard, Mittman, and Bethel. That was very, very informative. And we do have some questions that we'd like to get your perspective on. And then I just want to remind all of our attendees that if you do have questions, that you can type those into the question box. And we will answer questions about the content of today's webinar, as well as the profession, since we have great experts on the panel, or if you have any questions about the admissions process at SCNM, we can answer those as well. So the first question, I think you touched on it a little bit, Dr. Girard, but can you speak a little bit more about incoming ND students and their ability to do clinic shift rotations in the pain clinic, and if so, when in their medical journey at SCNM that might happen?
Sure. So students will begin their clinical training generally in their second year. Their first year, although I should maybe amend that, their first year they start with field observation out in the community, and then they begin direct patient care under the supervision of their attending in their second year. We have a few places where students can participate in their clinical education. Our main teaching clinic is here on campus, and we call that our medical center. We also have 9 community clinics throughout the Phoenix metro area that provide care to underserved populations. And then, as we've already stated, we have the Pain Relief Center. Typically, those students who are seeing patients in the Pain Relief Center are more senior students, and they tend to have more of an affiliation or interest, I should say, in pain management. And so they're able to do that throughout their clinical training, but as I say, typically later in their training.
Great, thank you. Can you also speak a little bit about the modalities used in the pain clinic and whether those are within the scope of practice for naturopathic doctors, and if simply passing the NCLEX would grant students the appropriate licensure to practice those modalities, or if students would need additional training?
So there's actually more than one question there, so let me do my best to dissect that. First of all, the modalities that we have down in the Pain Relief Center include, as you've heard today, naturopathic medicine, acupuncture, interventional pain management, which includes injections under fluoroscopy. We also have a cryotherapy unit, so cryo is incorporated, along with the traditional naturopathic modalities like nutrition, homeopathy, etc. All of those things are within the scope of practice in the state of Arizona. And so whatever we do under the direct supervision of the attending physician would be appropriate training from a scope of practice standpoint. However, if a student or graduate is going to move out of state, there's different scopes of practice state by state, and it's up to the graduate to understand the limits of scope of practice in those individual states. That's very important. NCLEX is the licensing examination, and we have 2 steps. Step 1 is basic sciences, typically taken at the end of the second year. Step 2 is clinical sciences, typically taken right after graduation. Passing those exams allows a graduate to then be licensed in whatever state they plan to live in and practice in. So NCLEX does not necessarily grant someone a scope of practice. It's more of it's a licensing degree. It allows, or exam, it allows them to be licensed in a particular state.
So if once a person passes NCLEX, gets their license to practice naturopathic medicine, they have the right to practice to practice some of these injection therapies, but they also have the responsibility to do whatever training is necessary so that they can do it responsibly. And so I think therefore is that's the impetus behind the continuing medical education and the certificate program.
Thank you. Dr. Girard, you mentioned the cryotherapy chamber. Can you explain what that is?
Oh.
or Dr. Mittman,
Yeah,
or Dr. Bethel.
Dr. Mittman probably is the one who's had the most experience in the cryotherapy unit.
It's cold. And cryotherapy is it's a full body chamber where you stand in a chamber with your head sticking out the top. Nitrogen gas circulates around you for up to 3 minutes. And did I say it's cold?
Yes, you did.
Cold. And basically what you're doing is you are cooling the surface temperature to about 42 degrees centigrade. That doesn't mean that you freeze or you become hypothermic, because it's only 3 minutes. But what that does is it affects pain receptors and it modulates inflammation. And it was first used among athletes by the Dallas Mavericks. The year that they won the NBA title, they were the oldest. They had the oldest average age in the NBA, and that was part, instead of doing those full immersion ice baths, which are also cold, but they're for 15 minutes, and I don't think you could pay me to spend 15 minutes in an ice bath. but I did the cryotherapy on a number of occasions. Once prepping for a bike race after a particularly brutal ride, once after a bike crash where I separated my shoulder, and the recovery time from injury and the recovery time from injury was, just greatly accelerated. So we're thrilled that we have it, and it was very nice. One of our alums actually donated the machine.
Thank you. So we have time for just maybe just one or two more questions, and this one is a little bit more medical based. Can you speak to any of the therapies that you mentioned in the presentation that might be best for healing broken bones that are not healing?
Stem cells are what comes to mind immediately. Also, the cold laser can make a big difference. Usually circulation is a problem with that type of injury.
Yeah, the classic examples would be a carpal navicular or head of the femur, where it's actually a disruption of the blood supply to the...
So pluripotential stem cells can create capillaries in circulation. They can bring it in rather quickly in a number of days and really give you a leg up on healing. The laser can energize tissues without circulation and geometrically change your healing rate. So both of those would be good things to try in that situation.
Great, thank you very much. And I think we are out of time, so I want to thank again Drs. Girard, Mittman, and Bethel for taking time to talk about pain management within the scope of naturopathic medicine and talking more about the PRC. We're super excited to have the addition of the PRC on campus and just very excited to get students plugged into that. So thank you. If your question was not answered, feel free to email me directly and we can follow up with you and get you any additional information that you might need. So just as a reminder, there are lots of great opportunities to get to know SCNM. So for those of you that have not visited our beautiful campus or seen our new building, invite you to come out and get to know us on Discovery Day, which is our open house, and that's coming up on Saturday, November 14th. We also have a Student for a Day program that happens very regularly, as well as, of course, always invite students to come out for a campus and medical center tour. So you can always schedule those by reaching out to myself or anyone on the admissions team. We are currently, we still have a couple spots available for the fall class, which begins in October. We're also accepting applications for the spring class, which begins in April of 2016, and we'll be accepting applications for fall 16 right after the Labor Day holiday. So again, if you have any questions about that, feel free to reach out to us in admissions, and we'll get all your questions answered. So I want to thank our presenters again. Thank you, Dr. Girard, Bethel, and Mittman, for the informative webinar. This webinar has been recorded, and it will be posted on our website soon. So if you want to refer back to anything, you'll be able to do that. So thank you again, and that concludes our webinar.